Good morning, everyone, or afternoon or evening, depending on what time you're listening to this presentation, but it's being recorded in the morning. I would like to thank the chief residents, in particular Gene, for this opportunity to record some lectures for the internal medicine residents during these unprecedented times. I think if you would have told me that this would have even been something on the docket 2 or 3 months ago, I would have looked at you, maybe not 2 months ago, certainly 3 or 4 months ago, I would look at you with cross eyes and begin to question um, the validity of your central nervous system to a certain extent. But it's the reality now. So I hope getting these lectures together will augment your downtime, if you want to call it downtime. I know it's certainly different. And what we were requested to do were lectures that focused in the ICU. And I know some of you have had this very talk from me or from some of my PGY2 critical care residents over the years or my colleagues. Some of it may seem like old hat, but now you'll have it to where you can rewind, listen again, etc. And I hope that you find them helpful. So we wanted to start off with a core topic. This one's going to be a little bit longer than the 15 to 30 minutes that was requested. And it's because it is, when you're talking about the ICU, especially right now with COVID-19, in fact, it's changed how we're practicing this core component of care, is the management of pain, agitation, and delirium in the ICU. And I guess before I fail much further, to introduce myself, I've worked with many of you, whether it be on the ICU or MSD or even just an interaction on the weekend. My name is Chris Drogi. I'm one of the critical care pharmacy specialists in-house. I practice between the medical and surgical intensive care units. I'll occasionally go down to our emergency department as well and help out when they have issues in the SRU. I have been doing this job. I completed my specialty residency in 2010. So I had the pleasure of working through the swine flu era, which I've often quoted as my most challenging era. And then you have COVID, which matches the critical illness level of those patients, and there tends to be a lot more people. So certainly a very interesting time. I've been in the MI or SI as a clinical pharmacy specialist since 2011. When I immediately got done with residency, I worked in the ED for about 14, 15 months. I also serve as the PGY2 Critical Care Pharmacy Residency Program Director, where we take 3 residents per year. So many of you have worked with my residents over the years. And thank you very much for always including them and being excellent colleagues at the bedside and in other avenues. With that, I will preface by saying I'm doing this in hashtag WFM, working from home. I've let Gene know that as well. My wife, who some of you may know, is also a clinical pharmacy specialist. She just got done with rounds, and I hope she will be able to corral our 2 little ones. I have a 4-year-old and a 2.5-year-old who don't completely get mom and dad working from home. So I apologize if they interrupt, and hopefully we'll be able to edit it out if it comes to that. But I would imagine many of you are in similar positions and would understand. With that, let's get into the meat and potatoes of this. Meat and the management of pain, agitation, and delirium in the ICU. Objectives, we'll talk about causes and therapy of pain, agitation, and delirium in the ICU. Now, you're going to find me label this as PAD, partly because that was a mnemonic that they began to use in the 2013 guidelines. Now, the most recent iteration of the guidelines, they updated it to PADIS, which you'll see in the next objective bullet point: review and interpret the clinical practice guidelines for ICU PADIS management. The I and S stand for immobility and sleep hygiene, which all of this together is a spectrum of pan-critical care management. Immobility often being a consequence of PAD and the therapy of PAD, as well as just long-term critical illness, critical care, myopathies, et cetera, are very, very real components. In the time that I have for this, I don't have a whole lot of time to get into that, other than to say general management and optimization of PAD should minimize immobility. Again, I also want to be careful throwing in a bunch of caveats for COVID-19, but these folks who were having to sedate longer, having to use higher doses, having to have them more deeply sedated, are probably going to run into issues with immobility that many of us especially if you're post 2010 or even the 2014-2015 H1N1 outbreak, which was nowhere near as bad as the 09 2010 outbreak. It strikes a chord because some of those folks were paralyzed and deeply sedated for weeks, and we're also seeing that in some of our COVID-19 patients. Sleep hygiene also is an area where I could certainly get into pharmacotherapy around sleep hygiene. Many of you have seen us use drugs to try to facilitate or mimic some form of good sleep hygiene, but there just isn't the time to get deeply into that as a topic. We will talk about validated PAD assessment and monitoring tools. That's key to helping optimize the care of our patients. And then briefly, ever so briefly, discuss methods and benefits of reorientation. I don't want to take too much time on that either, but I think it's good to kind of have pan perspective on how do you also consider this while trying to liberate a patient from the ventilator. Kurt Sessler, he's at Virginia. He has been on the guidelines since their first iteration back in 2002. And he made this picture that I think this, if you look at this figure, it really captures the complexity of PAD and really trying to manage these patients. And he did this was from a paper in Chest in 2008. So this was before PAD was a thing. So he had it in the wrong order, if you will, anxiety, pain, and delirium. But up top, you have predisposing and causative conditions leading to anxiety, pain, and delirium. And I don't want to make it sound like anxiety, pain, and delirium are equal. They're certainly not. There's one component within this, and I think it's why Dr. Sessler did it this way. But pain sort of here centrally in the middle, and pain can certainly lead to anxiety. It can lead to delirium. It could lead to agitation. It really is sort of the initial part of the snowball of complexity with these patients. Then you have interventions, okay? And notice I'm not necessarily discussing all of them. You can read them on your own. And then the spectrum of discomfort or comfort and sedation here at the bottom. And for those of you who've been on the ICU rotation, what you know is many of you, you're going to be familiar with the Richmond Agitation Sedation Scale. And while we will discuss it later in this talk, it's captured here too. But you have two different scales that really do range from this unresponsive, almost inanimate level of sedation and coma to this dangerous agitation where you have somebody who is trying to rip your larynx out. Up here, what I like about pharmacy, and again, this is probably serving to a certain extent, but medications really the only component or causative predisposing component that is both a potential cause, and let me tell you, they are, right? Drugs are bad, down to also being treatment for the intervention or as an intervention for anxiety, pain, and delirium. So I would say with that, it's good to know that meds can certainly intervene, but side effects will end up potentially causing further issues. And you can't get into this bad loop of treating drugs to treat drugs, if that makes sense. Now, it's certainly not taking away from everything else you see up here. For example, being on the mechanical ventilator, we are no longer able to do simulations like we used to in the ICU rotation. And I don't know if any of you have gotten a chance to do the ventilator simulation. I've done it several times, as well as I was able to run the ventilator on multiple occasions. And it's an unpleasant experience. Even minimal settings can be a quite unpleasant experience. So we're going to start with pain. And believe it or not, there's data out there that actually define them. You can find definitions of pain as we would consider it in the ICU or in a patient in patient care in general. I ended up landing on one that is driven by anesthesiology, the International Association for the Study of Pain. I figure they're probably some of the best and most apt to define it for us. And they describe it as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And I want to take a step back here and realize that it's not just the sensory pain that we associate. Most of the time, when we think about pain, we think of some form of sensory pain. The emotional pain is there as well, certainly. And we've begun to recognize that more in the last 10 years, both from an acute standpoint in the ICU and even post-ICU syndromes. And it is very, very important. There is well-described issues of, in particular, PTSD, driven by some of that emotional pain in the experience of being in the ICU. And then I'll also point out that it's not just the actual but it's potential tissue damage as well. Okay. We're not going to do every bullet point in every slide, but perspective is important here. I'm not saying that you need to have your goal 0% of moderate to severe pain. There's too much subjective relativity in that. Patients overall, what is a 3 for one patient is a 20 for another, even on a scale from 0 to 10. Ultimately, remember, patients come in, they're supposed to have a pain assessment done in triage if they're able to have that done, right? Sometimes our patients, and oftentimes our patients are not. And I just want to make clear that sometimes it's a major victory to take somebody from a pain score of 9 or 10 to 8 or 9 or 7 or 8, which is still going to fall under the moderate to severe pain, depending on where you define your scores. But just know 77% is probably a little bit on the high end. It depends on what phase of their care that they were in, which wasn't clear in these studies. But nonetheless, something to consider. So just remember, this is a key point of this. ICU patients, they routinely experience pain, even at rest, okay? Sequela of uncontrolled pain, this captures at least the surface of it. Agitation, and then of course subsequent anxiety and delirium are in there. The stress response is very real. You guys have seen plenty of times. In fact, you guys have probably experienced this at different phases of life. Increased circulating catecholamines is really very real, right? You get activation of your sympathetic nervous system, the fight or flight system with pain. So tachycardia is very real. You get increased SVR, PVR, and there is an increased myocardial oxygen consumption, right? That's how our bodies are programmed. The relevance of that is not completely understood, and it's probably variant depending on one's baseline comorbidities. Hypercoagulability is very real here, and for many reasons beyond just the stress response itself. Immunosuppression, I apologize. I know some of you have heard me give this talk over the years, and I promise someday I'll fix the spelling of immunosuppression. Critical illness itself is immunosuppressive, not just immunosuppressive, but bone marrow suppressive. But uncontrolled pain tends to be a major component of that process. Persistent catabolism. And this is not at a parallel level of anything that you have if you're not critically ill and uncontrolled pain. This is extremely difficult to overcome, extremely difficult, if not impossible at times, to catch up. I do not envy our dietary colleagues, our metabolic support colleagues, as many of these patients tend to be very far behind, even after a couple of days. Critical illness and uncontrolled pain as a pair will deplete glycogen much faster than most other things, I shouldn't say things, it's kind of generic, but disease states that we could be presented to take care of. And again, it's not to say that all critical illness and uncontrolled pain is equal. If you have somebody coming in with, say, necrotizing pancreatitis and a large abscess around that necrotizing pancreatitis, something like that tends to be some of the most extreme situations where you're going to say deplete glycogen stores at a pace almost unheard of. I suppose about one of the only things that might challenge that is something like a large surface area, full thickness burn, something along those lines, which we won't necessarily take care of in the MICU or in most internal medicine areas. COVID-19, I will tell you, when we get these cytokine release syndromes and storms that we're seeing in the patients, I guarantee you that is something that could certainly test the realm of severe persistent catabolism as well. Pulmonary dysfunction is there, and there are many reasons for this. Ultimately, it can go back to this persistent catabolism and your diaphragm turning as thick as a sheet of paper and its muscular integrity. The functions of breathing while somebody is certainly intubated is very, very different when you're on a positive pressure mechanism versus a more innate negative pressure mechanism. Multiple components here. When you're assessing pain, routine monitoring is what's recommended, and using a valid, reliable tool is what is best. And the problem is that there's only 2 tools that have been validated. And what you'll find is we don't use either of these tools at UC Health, at least not yet. We're getting ready to make the jump to critical care pain observation tool. But there's behavioral pain scale, or BPS, and critical care pain observation tool, simply labeled as CPOT, but 1C because they got away with hyphenating critical care. And really, they suggest getting away from vital sign use alone, or an observational pain scale, which is interesting because we use the observational pain assessment scale. They may be driving for further assessment use, but outside of that, they tend to be a little bit more subjective. and can be potentially misleading even in folks who are well trained and well adapted to their use. This is just an example of looking at the BPS. Now, with both BPS and CPOT, they ironically started out as tools that were validated in non-intubated patients. So that's what you see over here. BPS-NI was actually the first iteration of this. With both of these iterations, you see you have the intubated patients, non-intubated patients. You have three categories: facial expression and then movement of upper limbs. And there's really no major differences in the techniques of observation between those two. It's the final category between vocalization. Well, most folks are probably not going to vocalize well on a mechanical ventilator. So what the folks did, there was a French group who validated this in intubated patients. They looked at compliance with a ventilator, which is an excellent surrogate in this regard, if not even a better surrogate overall. And what you have here is you look at a score, 1, 2, 3, or 4, that you can see across the top here, and then you add up the three categories. So you can either have a minimum score of 3 or a maximum score of 12 if they're making 4 in each category. So that's where the 3 to 12 comes from. The question is, what's the threshold to deliver some type of analgesia? Greater than 5. Think about that. It doesn't take a whole lot, right? So 2 2s and a 1, which is not an uncommon phenomenon in an ICU patient, and you've got it, or a single 4. You don't even have to look at the other two categories, because even if they just had a 1, they would qualify for some form of treatment for significant pain. Analgesic therapy, even as a pharmacist, drugs put bread on the table. I can't stress enough that drugs are bad. So if you can get away with non-pharmacologic therapy, the better. So something like relaxation, proper positioning in bed, injury stabilization if they've suffered some type of obvious physical injury, and then elimination of irritating physical, and I will throw in emotional stimulation. There are times, and I've been there plenty of times in my short career, where you as a person walking into the room to talk to the patient can be very irritating, and if it's not needed at that time, I'm going to come back in 5 or 10 minutes, and that could go a long way. Pharmacologic, no surprise, you have opioids and non-opioids. You see examples down there. We'll briefly discuss them. I will say briefly here, if you're a reference person, if you look at the reference down here with Dr. Barr and colleagues, these are the guidelines from 2013. Please be aware that there are new guidelines that were published in 2016. The first author, if you're interested in looking them up, they're also in critical care medicine, is John Devlin, Devlen. So I apologize for not updating throughout. Pain treatment. And some of these I will try to infuse as I worked with the group as an ancillary member for one particular drug in the guidelines. I will try to emphasize some of the changes between 2013 and 2016. But pain treatment really emphasizes preemptive therapy or non-pharmacologic interventions prior to invasive procedures. That can go a long, long way. And I would argue that the language around this has been further emphasized, as between the 2013 and 2016 guidelines, we've only heard and learned more and more about the opioid epidemic in the United States of America. IV opioids still remain first line, in particular for non-neuropathic pain, and using basically equipotent doses to treat similar pain intensity scores. You can use non-opioids to decrease or eliminate the need for IV opioids. Okay, what I mean by that is there's reasons why drugs like oxycodone, acetaminophen, hydrocodone, acetaminophen exist. Okay, why? Because having something like acetaminophen or NSAIDs, if appropriate, help effectively reduce the amount of pain of opioids needed for an analgesic purpose. If you've got neuropathic pain, you can consider gabapentin or carbamazepine. I will get into some of my isms there here shortly. Here are your opioids as far as analgesic pharmacology. Now, I won't lie to you. The table's here. You guys can look over it yourself. There are going to be certain components that I stress, and then please take some time to look through these. And this is always something you can print out, put in some type of peripheral brain or something. But here are your equagesic doses, both IV and PO. It's actually not the best chart, but there's reasons for that, especially with methadone and remifentanil. I'm not going to hone on those too much, but you could find good equianalgesic charts. There's actually one on the intranet through UC Health, and then plenty if you look online. You'll notice some variances here in IV onset and elimination half-life. For example, there's a reason why we tend to lean on fentanyl in acute situations, or why remifentanil is employed often in the OR. But you'll find that the elimination half-life, sometimes I find that this is a misunderstanding or misnomer with fentanyl. It is similar to hydromorphone and morphine in folks who do not have some form of renal or hepatic dysfunction. Obviously, methadone, that's a drug that you're not going to see an immediate effect. It takes 1 to 3 days. So don't expect methadone to help reduce your needs, if that's what you're using it for, of other opioids or sedative pharmacology in a day. It really does take 2 to 3 days. And then even when you're taking patients off of it, as you can see with half-lives of 15 to 60 hours, it will take some time for methadone to completely wash out. Fentanyl gets interesting when you look at context-sensitive half-life, as it begins to certainly prolong the longer a patient is exposed to it. As you can see here, 6 hours after an infusion, context-sensitive half-life is around 200 minutes. 12 hours, you're now at 300 minutes, which is certainly exceeding a 4-hour elimination half-life. And eventually you'll get to tachyphylaxis with fentanyl as well. There's no well-defined time frame, but you're looking at probably somewhere in the 4 to 7 day time frame. If a patient is still on a fentanyl drip, it's time to question whether another agent could be necessary. In fact, there's actually good data out there in the medical world in particular doing rotations between fentanyl and hydromorphone drips. And again, I promise I won't confuse too much, but with COVID-19, we are certainly being forced to do some early switching and other creative modalities because fentanyl is one of many drugs in the path that is short, in fact, somewhat significantly. Metabolic pathways is important to concern here, to consider here. You do have N-dealkylation with fentanyl. There's not major components here, but if you have people who have hepatic disease, it can accumulate. And then both hydromorphone and morphine undergo glucuronidation. And it's more relevant with morphine because you have multiple glucuronide metabolites that are still pharmacologically active and are renally cleared. So you have to be very careful. Over the years, that's actually been a common intervention I've had with internal medicine residents and even sometimes the ICU fellows, is when you have somebody come in with an acute kidney injury or maybe something beyond that, they get a morphine order put in. It's probably not the most ideal analgesic to use because it can accumulate not just it as a paired compound, in particular its glucuronidase metabolites, 3, 5, and 6 glucuronide morphine. Methadone is as you can see here, it interacts with a lot of the CYP450 enzymes. And again, as I mentioned, half-life and other pharmacologic dynamics can be difficult to consider long-term. As far as side effects, other information to consider, you can see, again, there's actually active metabolites there. I didn't mention the N-demethylated derivative of methadone, but that's relevant as well. Fentanyl, you tend to have less hypotension than morphine, but it can accumulate not just in hepatic impairment, but in patients who are underweight. Having composed an editorial for a paper that myself and one of my colleagues reviewed in critical care medicine several years ago, I can guide you to what I believe to be decent data to discuss that. Hydromorphone, you do have to be careful with hepatic and renal impairment, but it's not as prudent as it is with, say, morphine. And again, I will mention this for those of you who are in the unit or could be in the unit. We are using doses higher than what you see with the hydromorphone here, 3 milligrams per hour. We actually go all the way up to 6 milligrams per hour if need be. Sometimes I've even exceeded that back in the H1N1 days. Morphine does have a histamine release. If you go back, even it wasn't that long ago, there was morphine was the preferred agent to use in, say, because of what was believed to be a more fervent coronary artery, coronary vein vasodilation, more so artery, but vasodilation to enhance oxygen delivery to the myocardium or acute infarct. That has been softened a little bit, saying fentanyl can accomplish something similar, but it doesn't have the same level of histamine release. There's a reason why fentanyl doesn't have as much hypotension as morphine. I will say with methadone, just be aware that you do have to, it's fairly unpredictable. I will agree with that. And it is a QTC prolonging agent. So you've got to keep that in mind, as it's not uncommon for patients in the ICU at least to be on several QTC prolonging agents for pharmacology. Non-opiates, this is their table here. I'll tell you guys outright, probably one of the most pro-ketamine people in the country. Doing a lot of research on ketamine, both funded and non-funded. Some will be presented here later. It gained a lot of attention in the COVID world right now. And in fact, when I get done with this, I'm going to move on to writing my section for a review paper that it focuses on ketamine use in COVID. So you're looking at a fairly quick onset. The elimination half-lives you'll find are actually fairly similar amongst most of these agents on the list, with the exception of carbamazepine. Gabapentin tends to be a little bit longer. Ketamine does have a N-demethylated metabolite called norketamine that's out there. Acetaminophen can be used both PO, or can be used PO, PR, and IV. I will tell you guys, outside of a faster onset with IV, there's really not a whole lot of magic. Cost does come up about this. And yeah, a bottle of IV acetaminophen, I don't know. Last time I heard is maybe around $40 a vial. That may not sound a whole lot, but when PO acetaminophen is like 4 cents, when you begin comparing 4 cents to $40, and you look at the current climate of the hospital, which is it is losing money because of the epidemic. All of a sudden, a product that has 4 cents versus $40 can become a prudent focus and can make a big difference in the bottom line. Ketorolac and ibuprofen, whether you talk about IV, IM, or PO, it shouldn't come up that much in a lot of medical worlds just because of the implication it has on the proximal. Really, when you look at the vascular anatomy, I guess I won't get too specific, but the vascular anatomy of the kidneys, the afferent arteriole, you will have vasoconstriction, even short term, with use of NSAIDs through its mechanism of action of blocking cyclooxygenase, and some of the prostaglandins that are relevant out there. And in a population that are at high risk for acute kidney injury, or many of them having acute kidney injury or renal dysfunction, it will only worsen that, but they're there to consider as alternatives. And then your neuropathic pain agents, gabapentin and carbamazepine. Carbamazepine as a drug I would rarely use. I kind of wish they would get away from it in the guidelines. That's just an ism. It has number one, drug-drug interactions can be an issue. It does cause issues with sodium regulation. And as you can see, it's one of these odd drugs that actually metabolizes itself, reduces its own metabolism. Initially, it's a half-life of 25 to 65 hours, then 12 to 17. So very unpredictable agent. I will mention with gabapentin, half-life 5 to 7 hours. It is renally excreted, so if you're not careful, it can accumulate and lead to sedation and confusion in patients. So you got to adjust it for renal dysfunction, whether it be acute on chronic, or chronic. As far as other considerations, I will not deny ketamine does have, it's a phencyclidine derivative, right? So it's a mushroom. You will get some hallucinations or other psychological disturbances with this drug. I have rarely seen it with continuous infusion, and this is somebody who's seen it employed on hundreds of patients and have written papers on it. I sometimes believe it's overstated to a certain degree, but I will tell you, I could share stories at another time of seeing folks completely trip when given higher doses for, say, procedural sedation or for RSI or other components therein. You can see hypersalivation with ketamine. I won't deny that. The number of times I have had to consider hypersalivation for patients on continuous infusion amounts to 2 or 3 cases at most. And that's for situations where they probably had an underlying disease state that also resulted in hypersalivation. Regardless, you got to be aware of that because, especially when you're looking at it in use in sedation in folks who may be paralyzed or even not paralyzed, but are requiring prone position, hypersalivation when somebody's in the prone position can become problematic. So just be aware of that. Acetaminophen, the hepatic dysfunction is real there. So if somebody has active hepatic dysfunction, or cirrhosis for that matter, I probably wouldn't exceed 2 grams a day. So just keep that in mind. I already talked about some of the issues with ketorolac and ibuprofen. I would also keep in mind that these tend to inhibit, number one, some of the protective mechanisms of your gut's barriers, and it has antiplatelet activity. So just items to consider when looking at these drugs. I'm not going to talk again. I already mentioned my biggest issues with carbamazepine. I guess if there's one other issue to have people shy away from carbamazepine, it does have links to Stevens-Johnson syndrome or TENS, especially if a patient's known to have alterations in their HLA-B1502 gene. So again, just be aware of that. What about administration? So this is key. Stuff that you see that's bolded or bolded and italicized for emphasis is a big deal. Preventing pain is more effective than treating pain. All right. So this is where we really need to rely on our nursing colleagues to optimize this. But with us, on the physician and the pharmacist side, we have to make sure that we give the nurses all the tools in their armamentarium to make this effective. So this could be done on a continuous or scheduled basis. You can have supplemental boluses, order sets that are built in Epic to facilitate this. PCAs can be considered. We don't use PCAs all that often in the medical side of things. Maybe if you get into medical oncology, they could be considered, but very rarely in the ICU. If you see a PCA in the ICU, it's probably end of life in nature. So you could do that plus or minus a basal rate. I try to avoid basal rates unless it's end of life. Transdermal patches, whether it be fentanyl I have listed here or lidocaine, I will say this, you got to be careful. There's altered absorption in critical illness, whether it be, say, from something like subcutaneous delivery of meds like, heparin or insulin, and certainly transdermal patches. These folks, when you look at the level of anasarca they present with, they can begin resembling a water balloon. And I'm telling you, if you put a fentanyl or a lidocaine patch on a water balloon, you're probably not going to get a lot of absorption into that other side of the barrier. And it's no different for human beings. And really, that level of volume up would need to be addressed before patches would be ultimately effective. Pain therapy goals, assess regularly, at least 4 times per shift. You want to make sure that this is being done if you're taking care of these patients. Really, any type of pain that is noted should be treated quickly, no later than 30 minutes after an assessment. If that is not accomplished, go back to that picture from Curtis Sessler that I showed in the beginning of this talk. That snowball can roll downhill very, very quickly. And then prevention, pre-procedural sedation, seeing, if the patient is coherent enough, seeing if they need anything before putting in a line or whatever else you may do. And then again, bolded. What's key here is treat pain first and then sedate. A lot of analgesics, in particular the opioids and ketamine, will also be fairly profound in their sedative realm. Okay, most sedatives aren't great analgesics. Okay, there's some exceptions there, and we'll certainly hit them as we get to them. Pain care bundles. This again just reiterates. I'll leave this slide up for maybe 10 seconds just so you guys can look over them. But this just is straight out of the guidelines, stressing perhaps the approach of assessing first, then treatment, and then prevention, and that should go full loop. One could say that you should also prevent and work on preventing, so we'll reduce anything that you could find upon assessment.